Hello, everyone, and welcome to Allocating Scarce Medical Resources, Equity and Justice Concerns. I think this is a really interesting time to have a conversation about what worked with our crisis standards of care and who got access to necessary, often life-saving care during the pandemic. A few housekeeping remarks before we start. We are definitely welcoming questions. Please submit your questions through the Zoom Q&A feature, which is found in the meeting controls at the bottom of your screen. Or feel free to join the conversation or submit questions on Twitter. We're at Petrie-Flom, and you can use hashtag ChristStandCare. Again, that's hashtag ChristStandCare. If you have any technical issues, on the other hand, please email petrie-flom at law.harvard.edu, and we'll do our best to help you. We will be sharing the fully captioned event video with everybody who registered within 1 to 2 weeks, and then please share that link widely with your friends, family, colleagues who weren't able to make it today. If you like what you see today, and I very much hope you do, the best way to stay in touch with us and learn about our events, our research, our scholarship is to sign up for our newsletter, which comes out only twice a month. Please also check out our blog, Bill of Health, which hosts some really high-level, thoughtful takes on current events in health law, policy, and bioethics, as well as check out our upcoming events. We have a great one coming up next week talking about the situation of vulnerable individuals in this current phase of the pandemic. I hope you join us. With that housekeeping out of the way, I want to introduce our moderator, Stephen Wood, who is a visiting fellow here at the Petrie-Flom Center, as well as Director of Advanced Practice Providers at St. Elizabeth's Medical Center, McHugh. It's a real pleasure to hand over the event to you, Stephen.
Well, thank you, Carmel, and welcome to all of our attendees. We have a wonderful mix of people, including some healthcare providers, policymakers, and advocates. This will certainly make for some excellent discussion on this very important topic. And Carmel, thank you so much for inviting me. This is a topic that I have a significant interest in as both an emergency medicine and critical care provider, ethicist, and specialist in disaster management. I'm very honored to have the opportunity to moderate this important discussion. And we have just a wonderful panel, and I welcome them today here as well. So, without further ado, I'd like to introduce our panel. We are joined by Brendan Abel. He is a legislative and regulatory affairs attorney for the Mass Medical Society and faculty at the HMS Center for Bioethics. We're also joined by Dr. Alden Landry, assistant professor of emergency medicine at Harvard Medical School and the assistant dean in the Office of Diversity and Inclusion in Community, as well as a practicing emergency medicine physician at the Beth Israel Deaconess Leahy Medical Center. We have Ari Niaman. He's a senior research associate at the Harvard Law School Project on Disability and visiting scholar at the Lurie Institute for Disability Policy. And finally, Dr. Aaron DiMartino, assistant professor of medicine in the Division of Pulmonary and Critical Care and Biomedical Ethics at the Mayo Clinic. We'll have each speaker talking for about 10 minutes. As Carmel mentioned, we have a Q&A that you can ask questions, and then when we've followed up with the presentations, I'll take those questions and post them to our panel for our panel to respond to. So without any further ado, let's get started. Alden, I'd like to pass the baton to you to start this off, to talk a little bit about your clinical experience during this pandemic with this topic.
First, I want to start off to say thank you for the invitation to be here, Stephen. It's an honor to be a part of this panel and to have this conversation. I think it's good that we're having this conversation, maybe in this position where we're having a little bit of a pause or a respite from the waves and waves of the pandemic. I can tell you firsthand that we are not through this. I was working clinically in the emergency department yesterday. and I took care of more than a handful of patients who were receiving their first diagnosis of COVID-19 after 2+ years of being in this pandemic. So we are certainly not through this, but we are in a better position now because we have some more resources available to us. And we also have some time to think about this critical issue when it comes to potentially allocation of scarce resources. But I actually don't want to talk about what I was experiencing yesterday. I want to talk about my experience back in March of 2020 and April of 2020, when we were having we were experiencing this virus attacking our country, attacking the world, without a clear understanding of what was going on, how to best manage our patients, and really operating in a system where we had limited information, limited resources. And our hope was that we were going to do as much as we could to mitigate the virus and save as many lives as possible. And so as an ED doc, I got to see this pandemic firsthand. And it was an interesting vantage point to think about how we were actually caring for patients. And early on in the pandemic, I recall hearing someone say that this pandemic was going to be the great equalizer, and that we were all going to be impacted the same by COVID-19, regardless of race, ethnicity, income, job, insurance status, and all those other variables that we assumed would be the case. But we know it wasn't the great equalizer. And there were some groups that were disproportionately impacted by the virus more so than others. And what I would also like to say is we actually did ration care during COVID, and not in the ways that we are concerned about when we're talking about rationing ventilators or some of those scarce medications at an early time. But we did so in the fact that we were actually rationing tests and hospitalizations. And I can recall seeing the fear in a patient's eyes when I would tell them that we weren't going to test them for COVID because they met all of the marks that we had for COVID: loss of taste and smell, diarrhea, shortness of breath, a cough. And it looked like they had COVID, but we didn't have all the tests at our disposal that we needed to, like we do have today, to actually test them. And I said, you look fine, we're going to send you home. And they didn't have a clear diagnosis. We were putting down that we assumed that they had COVID, but we also assumed that they were safe to go home. Again, understanding that we had a limited understanding about what this virus was actually going to potentially evolve into and how it may impact others that they may actually be around. And so we didn't know what was going to happen to them in a day or two. And so we said they were safe to go home. And then they could always come back to us if they needed to. But let's go back to that statement that I made earlier about this being the great equalizer, because we all know that it wasn't. And it turns out that historically and marginalized communities bore the brunt of the disease. Early on, Black, Latinx, Native American communities took a heavy blow. And also our patients from lower income communities also took a hit as well. And oftentimes when we were sending those patients home who we thought that they looked well, we were sending those individuals home who were considered frontline workers, but maybe not to the same standards that we would consider a nurse or a technician or someone else who worked in the hospital, a physician, a nurse practitioner, or a physician assistant. We didn't consider them the same level of frontline workers, but they were the individuals working at our gas stations or at our grocery stores, or they were our bus drivers, or they were in other service industries that our country actually needed in order to continue to function. And oftentimes we were sending those same individuals home to potentially multi-generational households where they were with younger children or older adults who they could potentially spread the virus to. And they may not have had the same opportunities to isolate themselves in the setting of going to a room, locking a door, and being away from someone for 5 to 6 days, because they still needed to be a part of the caregiving for their families. And so at some point, I recall us having this conversation about potentially allocating scarce resources such as medications or ventilators, or maybe even more so talking about the hospital beds, because we were filling up and we were using adjunct resources, like here in Boston when we were using the event center for space for caring for patients. But what concerned me the most about when we were having these conversations is that we were making the assumption that the protocols that we were going to put in place, the pathways that we were going to put in place, were coming from a place that were free of bias, and that we would be able to care for all patients regardless, that, the same way that we thought about COVID being the great equalizer, we were going to use these pathways as a great equalizer without recognizing the historical context of medicine, the earned distrust of the healthcare system by minoritized communities, and the many pitfalls that needed to be addressed prior to the rollout of a system like this. And while I know that our other panelists can speak more eloquently to the pathways that some of the hospitals adopted, it's really important to point out that the burdens of disease that our minoritized patients suffer from are the result of years and years, generations and generations, centuries and centuries of marginalization by our healthcare system. And so when you overlay that with a system that potentially is going to look at conditions such as hypertension, diabetes, COPD, end-stage renal disease, creatinine clearance, all of which have a place in race-based medicine that we have practiced in our country for a long period of time, and potentially put our patients who are Black or Latinx in a position where they would not be able to get access to resources in the same way as other patients, it was really concerning. And what I could say here is that one of the things that happened here in Massachusetts was DPH was pretty active in this space, and they started to have conversations and bring in people from various community organizations, bring in individuals who had different backgrounds, ethicists and physicians. They had individuals representing other minoritized communities, such as individuals with disabilities. They had the NAACP as a part of this. And there was a conversation that happened and said, look, we need to think about this, because if we give advice, if we give direction, if we give a space from a DPH level, then hopefully our hospitals can follow. And then we can hopefully we can prevent the potential disparities that may come out from a situation where we are rationing care, and the individuals that suffer are Black, are Latinx, are Native Americans, are lower income individuals, are individuals with disabilities, and so that they are actually able to receive high quality care from a system that's free of bias, recognizing that medicine, unfortunately, has been rooted in bias for centuries. So maybe I'll stop there and then pass it back over to you, Stephen, and happy to have more of this conversation going forward.
Yeah, and Alden, we certainly will have more of that conversation. I was in a similar position at the same time and work in a community with lots of marginalized individuals, and that had a real impact. And we got to see, how that kind of zip code kind of breakdown of neighborhoods impacted, what people had access to. So I'm sure I will have some follow-up questions, and likely some of our attendees will as well. So I then will like to move the conversation on to Ari. Ari, can you take it from here?
Ari, you're still muted.
Ari, you're on mute, but we'll hopefully have you back on in a brief second.
Can you hear me now?
We can hear you now. Perfect.
Wonderful. I am so sorry.
Oh, it happens. If we didn't have someone that was muted during a Zoom webinar, it wouldn't be a Zoom webinar.
I think that's probably right. So before I begin, I should mention I serve as a consultant to the HHS Office on Civil Rights. I'm working on some of these issues, very much not here as a representative of HHS, purely here in a personal capacity. With that, I want to begin just by highlighting the fact that crisis standards of care policy is subject to a very interesting tension in that it's complex. It requires expertise in order to parse, but it's also fundamentally about values. And as a result, it's something to which there should be some degree of democratic accountability. And in the political science literature, this is not a new problem. If you go back 30 years, there's a concept coming from political science called venue shopping. It's very relevant for when we discuss the regulation of technically complex issues. Namely that we don't just argue over how to regulate, but we also argue over who should be doing the regulating. Baumgartner and Jones talked about, mostly in the idea, in the context of nuclear reactor regulation, this tension between whether or not nuclear reactors were energy policy and should be regulated by energy regulators, or environmental policy and should be regulated by environmental regulators. And when the more complex, the more technical sides of an issue are emphasized, there tends to be this focus on deference to experts. When the social or other issues that are impacted by an issue are highlighted, there tends to be more openness to other stakeholders in the decision-making process. And I think when it comes to crisis standards of care, we've really begun to see that over the course of the COVID-19 pandemic. Prior to COVID-19, crisis standards of care was primarily seen as a clinical or a bioethics issue. And the stakeholders at the table were mainly people who had a background in clinical care or bioethics. Over the course of the last 2 years, we've seen a tremendous amount of mobilization from disability rights groups, from racial justice groups, from aging advocacy groups. And really, they've made the argument that crisis standards of care policymaking also belongs in the realm of civil rights policy, not just clinical or medical policy. And that shift has had some very definite impacts on crisis standards of care policymaking itself. These charts are from a prior paper from some colleagues of mine and I. We coded every state crisis standards of care plan that existed prior to the pandemic and every plan that was issued or updated over the course of the first year of the pandemic, according to 5 domains relevant to people with disabilities, whether or not there were categorical exclusions, specific diagnoses, or functional impairments that were excluded from accessing critical care, whether or not the resource allocation protocol made use of long-term survival, prioritizing not just based on whether or not someone would survive their hospitalization, but whether or not they might survive a year or 6 months later, whether or not the plan prioritized based on resource intensity, deprioritizing patients who might be more likely to use more resources, and whether or not certain protections, such as reasonable modifications to prognostic scoring instruments like the SOFA or therapeutic trials for ventilators, were made available for people with disabilities, as well as protections against chronic ventilator users having personal ventilators reallocated when they arrived at the hospital. One of the things we found is, with the exception of long-term survival, which remained an active topic of debate well into the pandemic, as the pandemic proceeded, and as we saw more mobilization on the part of disability groups and other groups, there was a real shift in crisis standards of care policymaking towards greater alignment with disability advocate priorities. And here we see just each state's crisis standards of care policy rated on a scale of 0 to 5. We see in the later parts of the pandemic, there's much more alignment, reflecting more mobilization on the part of disability advocates, but also because of the scrutiny being applied to this issue, I would say a greater willingness and a greater feeling of pressure on the part of providers and state regulators to engage outside of the realm of clinical care and bioethics and in the realm of civil rights policymaking. And this is an area I would say that's had a lot of interesting implications. HHS actually just this past February issued formal guidance on civil rights implications of crisis standards of care under disability rights law. It spoke to many of these ongoing issues, including prohibiting the use of categorical exclusions for any condition for which care is not medically futile, prohibiting the use of long-term survival and resource utilization as allocation criteria, requiring reasonable modifications to be made to resource allocation protocols for individuals with disabilities. What we're really seeing here is a transition from viewing crisis standards of care as a topic for doctors and ethicists to have primary ownership of, to a situation where clinical expertise remains very important, but there's a conversation between the clinical side of the equation and the civil rights side of the equation. I would say that's really quite interesting, quite important, not just for the area of crisis standards of care, but because we've seen this mobilization on the part of so many different stakeholders for all kinds of other areas of bioethics that are often closed off and primarily engaged with by clinical and ethics stakeholders. Something we may see further discussions post-pandemic regarding medical futility policies, regarding quality adjusted life years, value assessment, and other areas where there is a stakeholder interest, but in the past, not stakeholder mobilization. Primarily, I come from a disability rights background, but I also want to highlight that, as one of the prior speakers mentioned, there are some very serious racial equity considerations with respect to crisis standards of care. Many racial justice groups join disability rights groups in objecting to resource allocation protocols that used long-term survival, noting that because life-limiting chronic conditions were higher as a result of systemic injustice in the Black community and among people of color, the use of long-term survival didn't just disadvantage people with disabilities, it also disadvantaged people of color. There's also an emerging literature noting that the most common measure utilized to measure short-term survival in crisis standards of care protocols, the SOFA, or sequential organ failure assessment, appears to have a racial bias. And there have been various efforts to try and address that. Massachusetts proposed a modification to the creatine score component of the SOFA. Recent research suggests that that doesn't appear to solve the issue. Some folks have proposed taking the creatine component of the SOFA out altogether. But it's a real concern because even though there actually is some consensus that prioritization using likelihood of short-term survival during the hospital stay is ethically and legally acceptable, there are, obviously problems if the way we have to measure that results in the systemic deprioritization of Black patients relative to white patients. There's also been a great deal of advocacy by aging groups. Justice and Aging, a number of other organizations have been particularly active. Again, a lot of focus on opposing the use of long-term survival, which remains an issue, I think, including in Massachusetts's crisis standards of care plan, which I believe does deprioritize patients who are seen as less likely to survive the next year. But there's also been a lot of discussion in the aging policy realm on other issues too. A number of state crisis standards of care plans used what's termed life cycle considerations, or the fair innings principle, to deprioritize older adults and some relative to middle-aged adults and middle-aged adults relative to young adults as a tiebreaker in their state CSC plans. It's something many aging advocacy groups have objected to. And then there's also been some very interesting discussions as to the use of age or related constructs like frailty due to their relevance as a predictor of short-term mortality. And if there may be a difference between the use of age as a tie-breaking principle because of a judgment that younger adults have had fewer opportunities and thus have lives more worth living, which is likely impermissible, as compared to the use of age because it is in some way clinically relevant to survival. So that remains an active issue, probably will still continue to be debated in the coming months. I just want to close, since I think I'm at the end of my time now, by just highlighting a couple of questions I'm hoping we can get into in our back and forth. Namely, there is definitely a tension between clinical perspectives and civil rights perspectives on this topic, but there's also very much a need for both groups to be at the table. In the past, I think the civil rights objection has been the feeling that clinicians and ethicists were chairing the table, and we were really off to the side. So I think the question that we have to grapple with is, can we come to some point where there's really shared ownership over crisis standards of care policymaking, and we don't necessarily privilege either perspective? I think there are also some really interesting conversations to have about how we highlight the issue of class, which has not been given the attention it deserves in CSC policymaking, and a whole host of other things, which I hope we get to in the Q&A. So thank you very much, and looking forward to continuing the discussion.
Well, thank you, Ari. And this has been a nice progression from looking at the perspective of the frontline healthcare provider in emergency medicine and making these decisions, to then kind of some research data and looking at which groups are impacted and why. I think, Brendan, this leads nicely into your focus, which is going to be a little bit more along the policy lines. Can you take us there?
Happy to, Steve, and I agree. It couldn't have been a better setup. So thanks to my preceding panelists. And good afternoon, everyone. It's such a pleasure to join the panel. Thanks to Carmel and Glenn and the whole Petrie-Flom team for putting on this event. And thanks to Stephen for, I think, coming up with the idea. I have to say, over the last several months, as I have kind of increased research in this area and have reached out to experts all over the place, the prevailing response is thank you. Thank you for continuing to talk about these issues. It's amazing how quickly so many policymakers' attention has moved on. So I extend their thanks to all of you for holding this today. And so, as Stephen noted in my bio at the outset, I'm a healthcare attorney. And my primary focus is at this intersection of the practice of medicine and public policy. I study, I practice law and advocacy at this kind of intersection between law, government, and clinical practice. And so, of course, crisis standards of care was a huge part of the work that we've undertaken over the last couple of years. And what I really hope to get into is not only the value of making sure we get right these critical algorithms in terms of triage and clinical decision-making, but also making sure that we are structuring these clinical guidelines to be providing due guidance and clarity to the clinical community, and also having an understanding as to the relationship between these crisis standards of care guidelines and the law. What exactly is their standing in the eyes of the law? And so I would like to start with addressing some of the most practical issues. These crisis standards of care, I think we'll spend a lot of time talking about, and there have been many folks that have talked about the how and the why of crisis standards of care, but I'd like to spend a couple minutes talking about the when and the where. And then perhaps I'll return to the what in just a little bit. So on this issue of when, the critical issue of when, I'm not just referring to this abstract notion of when precisely do we contemplate the shift from a duty to the individual to a duty to the community, but literally when and how do crisis standards of care actually take place? When do they take hold? Who should be the person making the decision to invoke a crisis standard of care? Many states make this a formal declaration of a governor or a secretary or commissioner of health. And while there is merit to a single authorized individual, I have concern about the politicization of healthcare that we saw during COVID-19, and it has suddenly made this decision all the more important and politically charged. You begin to question whether elected officials are necessarily being put in a situation where invoking a crisis standard of care is an admission of systemic failure, or whether the politicization of the end of life care and the rationing of care and death panels has made all of this a political vulnerability that inhibits invoking crisis standards of care when they may genuinely be needed. So I think attention needs to be paid to whether there is a quantitative marker that could be either an independent trigger for a crisis standard of care, or at least provide some type of guidance or even cover to the person who ultimately is authorized to invoke crisis standards of care. In Massachusetts, as I have reached out to any number of clinical or legal experts over the last several months, there is still confusion as to whether we actually had a duly invoked crisis standard of care in Massachusetts, and these are among experts and leaders in this field. In addition, for the where, I think there needs to be crystal clear clarity about exactly what happens and where when a crisis standard of care is invoked. In Massachusetts, during the announcement of the finalized crisis standards of care guidance, it was noted by the state that the guidelines were ultimately voluntary. This came as a surprise, as a major tenet of the crisis standards of care, of course, is consistency across a healthcare system. It was also surprising that a voluntary crisis standard of care begins to portend a situation where some hospitals may be operating under a crisis standard of care and some are not, where some may be operating under a certain crisis standard of care and others may be operating under an altered or different crisis standard of care that ultimately underlie that there can be fundamental differences in clinical care, even under this construct of a crisis standard of care. And so this leads to my primary concern about our most recent experience with crisis standards of care. I think that many may serve as useful, perhaps essential clinical guidance tools. At best, they can provide clear guidance on how to justly and equitably triage or distribute scarce resources. The mechanics of how crisis standards of care guidelines are created is essential. We have learned so much in Massachusetts about how challenging it is to create a truly equitable crisis standard. And so much of this comes down to process. We need to drive a far more inclusive process that puts the right people at the table from the outset. We need to create a process that thoughtfully and equitably and inclusively solicits community input and that allows for continuous input. And of course, none of this works well under the threat of an impending or full-fledged crisis or pandemic. And so, of course, we need to be bringing together community stakeholders to have these important conversations outside of the threat of this impending crisis. And I think we need to really take a step back and begin to evaluate truly alternative models. There's a great article recently on can we take a restorative justice approach to crisis standards of care? How can we genuinely bring in multiple stakeholders, just as Ari highlighted, to drive the creation of these crisis standards? But to return back to this lack of consistency, what I really think this begins to do is challenge the legal status of a crisis standard to begin with. If we do not have a clear understanding of who is invoking, when they are to invoke, and whether or not there is consistency across a region or a health system or a state, how do we truly understand what the legal import of a crisis standard of care actually is? Does the very nature of a crisis standard of care developed by the state suddenly shift the standard of care in the eyes of the court and of the law? Would instructions to a jury about care provided during a crisis include reference to a crisis standard of care document or guidance published by the state? Would it be cleaner to publish the guidance document with an accompanying state law that has been passed by the legislature that very clearly delineates the legal status of a crisis standard of care document? And lastly, are crisis standards of care sufficient to address all of the challenges and threats to the legal standard of care during something like the last 2.5 years of clinical practice? In other words, does the state have an obligation to adjust how a judge and jury may evaluate a malpractice case in circumstances outside of a formally invoked standard of care, but where we know the clinical care was provided in far from standard circumstances? And so here quickly, it's important to acknowledge, of course, that a standard of care is meant to be flexible. It's dynamic and it is fact specific in medical practice and in the eyes of the law. And so many have contended over the years that this really obviates the need for a crisis standard of care, at least in the eyes of the law. But I think that COVID has challenged even the most flexible conceptions of a standard of care. For example, when primary care physicians were asked around in ICUs, is the standard of care of this average qualified, is it an average qualified critical care physician, or is it the average qualified family physician providing critical care medicine? And while standards of care generally take the notion of resources available into account, will a lack of human resources be adequately considered? Will all the permutations of the lack of sufficient resources truly be held into account with a flexible common law standard of care. And so I think state legislators need to take seriously to think about what additional liability protections may need to be codified in addition to just care provided under a crisis standard of care. And I think that state legislatures need to work cooperatively with departments of public health and with these committees that are creating these crisis standards of care, so that as you have hopefully a community-driven, inclusive crisis standard of care guidance document that comes out, there is clarity both within that document about how and when it is going to be invoked, and then also clarity from a state legislature to articulate exactly what the legal standing and the legal import of that crisis standard of care document is. And so I will leave it there as hopefully some areas that we can discuss further today, or areas that we can all work on together. I know that there were a lot of very dedicated people, both within government and outside of it, that worked so hard to try to create these optimal crisis standards of care. And I have significant concern that even if we're moving towards a more just, equitable distribution framework, that if it is not accompanied by the sufficient structure and sufficient understanding of its legal status, that they're never going to fulfill their true intent. Thanks so much.
Oh, thank you, Brendan. And that's certainly going to evoke a lot of conversation. I agree. I think that there was a great deal of confusion here in Massachusetts, and I know from my colleagues across the country as well, as to whether or not these were actually invoked, what protections were afforded to us, and how they could be equitably carried out, as well as, and we'll come back to this, who were the voices of those that were, developing these crisis standards. So we've had a bit of a Boston-centric panel discussion here so far, but now we're going to throw it out to the Mayo Clinic. And thank you, Dr. Aaron DiMartino, for joining us. You're going to round out the moderated portion of this section. And please, again, for our attendees, if you have questions, please post them on our Q&A. That's going to be our next section coming up. So I'll be fielding those questions and posing them to our panel. Without further ado, Dr. DiMartino.
Thank you. So I'll begin by introducing myself by way of a disclosure slide. I am an intensivist and ethicist, and that means that I approach any ethical dilemma with one foot firmly planted in my clinical practice in the intensive care unit. It also means I'm a pragmatist. And so it's my pleasure to anchor this amazing panel by talking about the hazards of implementing or operationalizing crisis standards of care kind of through the eyes of a clinician/ethicist. So today I'm going to touch upon 3 hazards that I can see inherent to implementing crisis standards of care clinically. So in the previous panelists' comments, you've heard about threats to disability and BIPOC communities. But here I'm going to touch upon the treacherous transition from the page to the bedside of policies. And this is an oft ignored, I think, subject, but one worth fleshing out during the course of the talk. So we'll be talking about the diverse policies and practice settings in which they are being implemented or were designed to be implemented. And then I'll focus on triaging critically ill patients specifically. And finally, I'll close with some comments on perhaps an even greater hazard to fairness or justice of operating without guardrails under conditions of austerity that bear a striking resemblance to crisis standards of care, but haven't been formally designated so. So there are a few loose threads that tie together pandemic scarce resource allocation policies across the United States, including guidance from the National Academies of Medicine and oversight from the Office of Civil Rights. Most states have actually issued some manner of ethical or clinical guidance to guide allocation of scarce hospital resources. About 40 states have done so. But others have left this type of direction to the regional departments of health, municipalities, or individual healthcare institutions. And there are clear benefits to a unified approach to resource allocation across a catchment area or even across an entire state, particularly if that guidance does respect the dignity of all lives and takes steps to diminish systematic disadvantage. But adapting a shared policy to both a critical access hospital and an 800-bed tertiary care medical center poses its own unique challenges, as we've seen across the country in states including Minnesota. Questions arise such as who should perform triage? What type of training should they have? What kind of patient information can they access to triage patients? And can decisions to withdraw or withhold life-sustaining therapies be appealed? Implementation plans vary greatly across institutions, even within a given jurisdiction, all adhering to the same policy, particularly with regard to who would be tasked with assessing severity of organ dysfunction at the time of presentation, the SOFA scores and other analogous scores to be used at the time of triage, and also to assessing the burden of comorbid illness co-incident at the time of presentation. So permutations in different hospitals' triage scoring plans range from enlisting multidisciplinary teams that also have on-call consultants that can be called in to opine on specific disease states for specific patients, to relegating this to a single individual, a nurse. And this is consequent to the resources in a given hospital, which are vastly different in a large medical center to a critical access hospital. But I would argue that it takes tremendous clinical judgment to assess somebody's chronic disease status when you meet them in extremis at 2 o'clock in the morning. And I'm guessing Dr. Landry would agree with that statement, having also met a lot of patients in these circumstances. And so, as you've heard, many states have attempted to kind of pull together and unify patient assessment by creating lists of chronic conditions that would deprioritize or outright exclude patients from accessing critical care. Likewise, plans for triage teams' access to medical records were substantially different from hospital to hospital, even across states that were using a unified approach to policy. And that illustrates varied opinion about how to fairly assess burden of comorbid illnesses. And these are even just when you're thinking about illnesses that might have a bearing on likelihood of survival to hospital discharge, as we were trying to do in the state of Minnesota. In some places, the bedside team would score the patient and then pass the score to a triage team. In other cases, the triage team would have unfettered access to the medical record. The state of Washington actually took an exemplary and very deliberative approach to arrive at a systematic chart review kind of choreography or process for all patients receiving triage scores, incorporating in stakeholder input from, amongst others, disability rights advocates. But this type of procedural planning is the exception and not the rule. If you live in a state that instructs you to incorporate prognosis, say, for advanced heart failure or for metastatic cancer into patient prioritization, it's difficult to imagine doing so without any access to medical records. Short of a systematic, consensus-driven approach to chart review, the concern is that triage officers could be exposed to biasing information about patients in the medical record, such as their picture or their occupational history or even their carceral status. That they might be uneven in their evaluation of cases, doing a deep dive into some charts and a more cursory chart evaluation in others. And that these biases and inconsistencies would in turn translate into differential treatment of different individuals. So to summarize my concerns about crisis standards of care, or the ones that I've mentioned so far, individuals are exposed to vastly different policy approaches to pandemic resource allocation, depending on where they reside. And many of these policies contain lists of chronic conditions that are potentially discriminatory, as you've heard from me and other panelists. Also, they're exceedingly difficult to operationalize because of the degree of medical judgment that would be required. Shared policies across a state or a region are subject to tremendous pressures as they're adapted to different practice settings with different resource availability to support fair triage procedures. But what happens when there are no guiding principles established, no effort to harmonize resource allocation practices between neighbors, when there are no systematic attempts to prioritize patients by illness, severity of illness, when there's no formalized retrospective review process, and little clarity about where along the continuum from contingency to crisis conditions we actually are. The hard-fought protections against discrimination and access to care, against unilateral decisions to withdraw or withhold life-sustaining therapies, against pressuring older adults or persons with disabilities to forego aggressive treatments for the good of others, or ostensibly because of scarcity within the context of the pandemic, those protections are all lost. Minnesota, to my knowledge, is one of the only, or maybe the only state that has issued guidance, ethics guidance on the transitions, the confusing, fluid transitions between contingency and crisis conditions, and how they should or should not impact patient care. We created this document specifically to protect against unsanctioned, unjustified, ad hoc rationing and other deviations from patient-centered care that were not functionally equivalent to care that would have been received under conventional conditions. As I reflect on American ethicists' response to the COVID-19 pandemic, I think we could have done more to protect patients by not focusing so exclusively and intently on crisis standards of care and averting our eyes from the injustices that were proliferating under the conditions of contingency conditions as we awaited a declaration of crisis. And there's still more work to be done in both the crisis and contingency spaces around engaging in policy revision iteratively with community engagement, around planning and practicing fair triage procedures, and also expanding our focus from crisis conditions to contingency conditions in the way in which they have and will continue to impact patient care moving forward.
Thank you so much. And thank you again to all of our panelists. This has been just a wonderful discussion, and we've really, kind of taken it in many different routes and looked at not only clinical, but also law and policy, and then kind of brought it back to kind of the ethical view of this topic. We have about 10 minutes left, and I want to prioritize some of the questions from our attendees. This first one, Brendan, I think I'm gonna throw your way, but I want to open this up to our other panelists as well. This is a question about the language, and the language crisis standard of care seems to be medical malpractice focused, and incorrectly suggests that there is a general standard that is applied to a wide range of different clinical presentations, and B, that during the crisis, they all change in some consistent way. And are we really talking about rationing and prioritization? And so how would you comment on just the terminology crisis as standard of care?
So first, I mean, I agree. I think that there are an unfortunate many different uses of this same term crisis standard of care in many different contexts, and it leads to a lot of confusion. There is fundamentally, it generally, I think, is connoting this shift from a usual standard of care and then contingency care, where we are operating in less than ideal circumstances, and moving towards that notion of crisis standards of care is where there really likely is some type of scarce resource, whether it be a human resource or or some type of other medical resource that likely is in some way, kind of a life-sustaining or life requiring resource. And with that shift, of course, I think fundamentally is acknowledging a shift from a duty of loyalty to the individual and suddenly moving towards a duty of loyalty to the community or to the public good. And when we see that shift, or when we see having to suddenly alter that duty of loyalty, is where we generally see this this shift to this concept of a crisis standard of care. But then what exactly is this crisis standard of care referring to? Is it talking about clinical guidance? Is it talking about, in Massachusetts, when we have this process to bring stakeholders together to try to develop a triage and resource allocation protocol? Or is it talking about truly an adjustment to the standard of care, which is a both medical and legal construct, and which may or may not need to be altered in some type of emergency or crisis scenario? So I tend to just say, yes, I agree. I mean, I think we're trying to use this single term to encapsulate many different kind of nuanced, similar constructs, and we likely need to address that. And then lastly, I would say we've had 30-something states in the US whose state legislatures have tried to provide some type of statutory legal barrier or legal protection to hospitals or healthcare providers during periods of the COVID-19 crisis. And that too has at times been referenced, as a crisis standard of care, although I think that is similar, but likely fundamentally a little bit different. So I'll pause there, hoping that's a little bit helpful, and would love any other input from my fellow panelists on that question of how we define the crisis standard.
I think the questioner is right. We are really, at least in this panel, more talking about prioritization or rationing. And I think one of the challenges with the reliance on, and I don't want to call it exclusively a euphemism, because as you say, Brendan, there's a broader universe that crisis standards of care encompasses, of which prioritization is a part. But one of the problems with us not being frank with that language is it, again, reinforces the idea that these are technical questions rather than questions of politics and questions of values. So I think one of the advantages of shifting to a discourse that's quite explicit about this debate being about rationing or prioritization is it signals to non-clinical stakeholders what's at stake, and makes it easier for a more democratic and transparent process of deliberation.
Thank you both. That's I think you both framed it perfectly, and I hope that answers that question. In the interest of time, we have another question about triage. And Alden, you mentioned triage in your introduction. So can you tell us a little bit about what that term means and what this meant during this pandemic and how it impacted your ability to provide care as a provider?
I really want to just reference this because we were talking about terminology, and we we're talking about how we're going to triage and decide who gets what. And, one of the things that often happens in the emergency department is patients are triaged for when they receive care. Individuals who have numbers, that indicate that they may potentially be sick, get a higher emergency severity index or ESI score. So if they have a fever, their heart rate's up, their blood pressure's low, all of these things matter. And one of the things that both Aaron mentioned, I heard Ari mention, as well, is the fact that individuals who are doing this triage need to be trained and need to have an understanding of the process. Well, what often happens is there is bias that is introduced even as early as the triage process. And I won't even bring this into COVID. I will bring this into something as simple as a pediatric fever. There is a study that came out not too long ago that said that when you control for all the other factors, Black patients over the age of 1 who present to pediatric emergency departments with a fever are more likely to receive a lower triage score, meaning a 4 or 5, than a white patient. And this means that that lower triage score will mean that that individual will likely wait longer in the emergency department. Along those lines, yes, those are hard data points. Lower triage score means to longer wait times. But in addition to that, there is what happens on the practical side of things when we are thinking about patients and how sick they are, because we assume that the patient isn't as sick because they have a lower triage score, because someone has already planted that in our mind that this individual is a little bit healthier and may not need as much resources. So I just think we need to really be careful as we think about what we're talking about when it comes to triage, because bias is introduced so early in the process, and our marginalized patients are the ones that are going to suffer when we use these processes and individuals aren't properly trained to triage patients accordingly.
Yeah, I mean, I think triage and prioritizing patients, I mean, triage literally comes from the French trier, to sort. And it's part of our medical training. It's part of our practice every day when we're running low on beds, trying to determine who gets the last ICU bed, et cetera. But this is the, you know, a highly unique circumstance in which there is an overlay or an interdigitation of policy interests and public input into what has historically been a clinical practice, and under circumstances of tremendous pressure. And so I think that's, would just add that point.
I would agree with both of you, and also, you know, triage is something that we do both in EMS, which I've been, you know, in EMS for many years, as well as in the emergency department. But it's less, you know, common for it to occur in the general medical wards and in the ICU. And that's something we saw quite a bit during COVID, which we were asked to go to a patient that's on a general medical ward and determine whether or not they can take our last ICU bed among the 4 or 5 other patients that potentially could use an ICU bed. And there's probably even less training, you know, in that area for triaging someone who, you know, who is going to get this one valuable resource, and how do we, you know, take all of these factors and determine which patient's most suitable to take that last bed. The other, and I think we'll need to finish up on this one last question, which is, and this is something I think, and I've spoken on this piece as well, in that's equity in and around advance directives. And what do you feel the impact of advanced directives would have on these, you know, these quote unquote crisis standards of care, or let me just say, you know, sharing of scarce resources? Dr. DiMartino, from the critical care side, would you have a comment on that?
Yeah, I think that advanced care planning is important. It's hard to plan for unforeseen circumstances in the future. And also, especially the unforeseen contextual features now, where somebody might be kind of thinking about others as they're making a decision about whether to accept or not accept life-sustaining therapies or a trial of intensive care therapies. That said, I have a lot of concern about the manner of deployment of advanced care planning and potentially pressuring of individuals of advanced age or with disabilities to forego or to decline for the sake of others during the pandemic at times when potentially that sacrifice was not at all justified by resource scarcity. I invite others to comment as well.
I think the concerns are very real. Obviously, advanced care planning is a very important part of clinical care and conversations with patients, regardless of whether or not there's a crisis. But there have been increasing concerns about coercion in end-of-life decision-making. I know many states, in response to these concerns from disability and aging advocates, have introduced language into their state CSC plans, explicitly indicating that providers must take steps to avoid conditioning the receipt of care on the acceptance of any given advanced care planning decision. At the same time, there's also been some worrying proposals to require DNRs for certain populations. So I think that's an issue that remains actively contentious.
And I would just add that it also goes back to trust or mistrust in the healthcare system, because we've had patients come in who are very ill, and the concern is are we going to limit the care that an individual truly deserves because we have a piece of paper that says that they may want certain things performed and other things. And I think the coercion point is a huge point, Ari, that we have to make sure that we're not forcing patients into this, we're not forcing families into this, and making sure that this is a conversation that happens well before individuals are in a position to potentially need this, and making sure that there's an understanding and a trust within the healthcare system before a patient considers signing a DNR or DNI form.
I'll just say, if I can chime in for one more point on this. I think this speaks to some of the rhetorical divide that we're going to need to figure out in building dialogue between clinical and civil rights stakeholders. Because of course the construct of civil rights law and civil rights advocacy is not to trust, rather, but to have an enforceable system of rights and oversight and monitoring. But of course, you know, from the clinical side, there needs to be some degree of trust between doctors and patients. And we want to build a trusting relationship so that patients can feel a greater sense of trust in the healthcare system. And I think we sometimes end up really struggling with these conflicting imperatives. And I don't know necessarily what the solution is, but I'm really glad that we're entering into this discussion, because I think it's so crucial for the work we are all here very committed to.
Well, thank you all for joining us today. Thank you to our panelists. This has been an informative and enlightening discussion. I think we might need a part 2. There's still plenty more to discuss. I wanted to thank Carmel Sacher and the Petrie-Flom Center for providing this space and time for us to discuss this important content, and to Laura Chong and Chloe Reichel, who on the back end helped to actualize these programs and bring them to fruition. Thank you to all of our attendees for joining us for this program. We'll be posting this hopefully on our website in a few weeks, so please make sure to check that out and share it widely. Make sure to visit the Petrie-Flom Center website for more programming, as well as our Petrie-Flom blog, The Bill of Health, accessible from our webpage. And check out some of the upcoming events, including the Science of Addiction that will be coming up on May 17th, and Considering the Needs of the Vulnerable in the COVID Pandemic coming up on May 20th. And of course, the 2022 Petrie-Flom Center Annual Conference, which will be taking place in June. We thank you all again. Have a great day, and thank you for joining us.